don't want to miss when they start though. And the retail store is 209. That's up there. Oh, maybe she's talking. You should be able to hear her.
Hello?
Hello?
Hello.
Oh. Unmute yourself. Okay.
Hello, I'm just trying to figure out if the audio is working. This is Nicole.
Nicole, my name is Cindy Barrier. Can you hear me?
Yes, ma'am.
Okay, great.
Thank you.
This is Amber Phillips. Can you hear me?
I can hear you.
Yay.
Me too.
All right. Can you hear me? This is Jeannie Dairagi.
I can hear you. This is Alice Salthouse.
Wonderful. So glad that you're here with us. This is our webinar on chronic pain in older adults in North Carolina. And I just wanted to point out the slide on healthyagingnc.com. I want you to be able to know that you can go to this website for resources, evidence-based program information, trainer resources, and the trainer resources do include the paperwork forms that we require, as well as some sample marketing templates like brochures and flyers and press releases. So we encourage you to visit that. All right, so let's dig a little bit into the chronic pain information. So this is a summary, thanks to Janice Self, our data administrator, that summarizes the work that's being done in North Carolina. And what I want to highlight is this idea that the chronic pain self-management program is growing. And we're constantly receiving information, and in fact, The new data shows that from September of 2014 through through December of 2017, 29 chronic pain self-management workshops have been offered in 17 counties with 348 participants. So there's a rising demand and interest in the chronic pain self-management program. The feedback is that the facilitators of the program really like the information and the format, and the participants have a lot of good things to say about how it impacts them. So because of that, we have decided to go into this webinar that focuses on chronic pain, how it impacts the body through arthritis, how it affects mental health, and how it's related to opioid use and abuse in North Carolina, including some of the legislation that is happening. So we are having 3 guest speakers today: Cindy Barrier from Arthritis Services, Dr. Ann Newman, retired from UNC Charlotte, and then Heather Carter from the NC Division of Aging and Adult Services. So a thank you to all 3 of them for being on the call. And again, this is being recorded, and I will post the link on our healthyagingnc.com website. So with no further ado, let us go ahead and hear from Dr. Newman and Cindy Barrier.
Okay. I'd like to welcome everybody myself, and I appreciate you joining us. This is a subject that's very near and dear to my heart, as well as Dr. Newman, as we've served in the field of arthritis for more years than we want to really talk about. Oh my goodness. My hope is that you'll learn something personally today, because chances are you're affected with arthritis too. With the numbers we're talking about, the chances are great that you have some type of chronic pain as well as a participant, or at least I hope this information will be relevant for the work that you do. My name is Cindy Barrier, and I'm an old nurse from the field of orthopedics and arthritis. I've enjoyed a career now with an organization called Arthritis Services. Happy to report that we have joined in a partnership with the Linda Miller's Area Agency on Aging here in Charlotte. This has just been a great thing for us as a small United Way agency to do. And I hope and pray that we're going to grow enough to be able to serve all the 9 counties that this Area Agency on Aging serves. We do have a product that we place out in senior nutrition programs that it fits the time constraints of which the people have to be able to stay in the senior nutrition program during any given one time. So I'll talk to you blue in the face about that, so I'll try not to do that. At this point, I want Dr. Newman to introduce herself so that we won't stop when we get started.
Yes, again, welcome. I'm Ann Newman. I'm also an old nurse, older than Cindy, but I'm recently retired from UNC Charlotte, and my field has been primarily in the area of mental health. But as I often tell people, that while I do checkups from the neck up, arthritis pain and other pain is from the neck down. So we have lots in common and work together. Cindy and I have worked together for a number of years.
Okay, so this slide here, this roller coaster slide, is going to stay up for a second before because I needed to tell you a little bit of introductory material before I even get started on that. But I think I needed to just back up here a little bit and talk a little bit about just the older adult and chronic pain. With all this talk about the opioid misuse and abuse now, the older population can't be eliminated from being at risk for that. And just like any other age groups, sometimes opioids, though, may have to be considered when an older person's pain just hasn't responded to other treatments, or when a major functional impairment persists despite treatment. And we do know that at least about half of all older adults are going to have some chronic pain. And chronic pain in later life is a worldwide problem. And a lot of times opioids are just poorly tolerated by the older adult, and all of us really, with side effects such as constipation, which is a really big thing, changes in your mental status and nausea, and these negative effects have to be weighed heavily against in using them. And and we have to constantly continue to monitor older adults when they're taking opioids. Physicians should always make sure that they're going to be stored safely. I know the family partnership has really been a good resource for that, in terms of getting out materials that are making sure that grandparents know that their grandchildren might be getting things from their medicine cabinets. So, and we always have to watch for the older adult that may use the medication for other reasons other than pain. So it's just a little more complex with medicating the older adult with those types of medication. There's age-related physiological changes, which can lead to altered drug absorption. They have decreased renal function, which may interfere with how that affects that particular older adult sensory and cognitive impairments. And balance problems might be there to start with, and they're going to be there possibly with the use of opioids. So it goes on and on and on and on and on. Not to mention older adults often are dehydrated, have an increased amount of fat, which all affects different absorption rates, slower metabolisms, and they're just, here again, just a more vulnerable group to these types of medications. And while arthritis is our focus right now, there's other reasons that folks that are older have chronic pain. You know, you think about it, their skin, they may get ulcers, burns, they don't heal right. What about the GI system? You know, how many of us know they talk a lot about diverticulitis and inflammatory bowel disease, and even constipation can be of the chronic nature, causing lots and lots of pain. Cardiovascularly, their systems often have advanced heart disease, peripheral vascular problems, pulmonary, COPD, endocrine. You see a lot of diabetic neuropathy. Kidney, even in the kidney, you know, chronic cystitis can set up a chronic pain problem. What about the immune system with herpes zoster and the post-herpetic neuralgia? Cancer, often, you know, cancer pain and depression. And that's a word we're going to talk a little bit more about later, but it certainly can be a double-edged sword, and whether it's part of the cause or the effect of chronic pain in the older adult. And there's a great article on this, and I'm going to leave the information with Jeannie on this because I think it's such a good article to go into all this information about the chronic pain in adult that it might be a resource you'd like to have. And for the purposes of chronic pain, we do need to define it. It's pain that persists beyond an expected time of healing, 12 weeks, at least 12 weeks. May or may not be associated with a particular cause or actual tissue damage. Chronic pain's bad for the older adult, or really anyone, because what do we tend to do? Uh-oh. Have I lost you?
No, you're still on.
Okay, good. We just lost our
Slides.
slides. Okay, I think we're back. It's not tolerated well with the older adult because of, you know, they have reduced mobility. That when you have pain, what do we want people to do? We want them to move. And here, you know, the pain's causing them not to be able to move. They avoid activities. They socially isolate. More depression, more anxiety. Just that big old round and round circle happens, and we've all seen that circle with the type of work that you all are doing in your evidence-based classes, the chronic pain cycle that sets up. So now we're here on these slides, and the reason I put together this whole pain set of slides here is because this is exactly how I have felt in dealing with people with arthritis for a long time now. The ups and the downs and the curveballs that get thrown to you at all different times while when a person has these diagnoses. You know, arthritis is very complex. It's a family of diseases under the word arthritis. At least 100 plus different kinds of conditions fit under this umbrella in which arthritis can be a symptom. And here again, the exacerbations, you know, we're down on the ground. The flare-ups is another word for exacerbations. And then we have remission type periods. And lo and behold, what do we do when we're in a remission period? We overdo. And I'm going to say this probably several times in this presentation that we do have to encourage the people that we work with that there is a delicate balance that you're always dealing with when you have one of the forms of arthritis. You know, you hurt, but you can't lay around and rest, but you can't overdo either. And sometimes that alone is the behavior modification that you need to be able to stress to people that have these different types of arthritis, that they're in charge. They can't not do anything. They got to do something, but it's a delicate balance. So next slide, please. So this slide's really just what we're going to be talking about. We're obviously going to be talking about what is arthritis, why are the numbers up, how do we manage it medically, more importantly, how do we manage it, self-management, pain. We're going to talk a little bit about pain and how it affects us physically and emotionally, with an emphasis on recognizing and treating depression. Next slide, please. Here's this growing burden graph. And this graph you can read there. You can see how in a matter of 20 years it's gone from 52 million and we'll go on up to 2030 of 67 million. But this slide doesn't show you the latest, that 2040 that number is expected to reach 79 million, or 26% of the population. Arthritis does affect more families than any other kind of health condition that there is. Let's go to the next slide, and there's just some facts here that I find to be fascinating, and I wish it would give me job satisfaction, but I'm still responsible for getting the grant money. But arthritis, the term arthritis is a leading cause of disability and has been for 15 years now in a row. 1 in 4 are going to have work limitations, so there goes costs, burden, 128 billion spent. And people with arthritis, particularly with mobility impairments, are twice as likely to fall 2.5 times actually, to suffer 2 or more falls. Half of them are going to have heart disease and diabetes as comorbid conditions. That just complicates things. And then you got that old obesity word. Yes, we certainly see that, and that does increase pressure on joints, but not everybody's obese. There's certainly a lot of very thin people that still have degenerative arthritis, and especially some of the autoimmune types. But here again, major quality of life issues. Next slide, please. More facts. Over the next 4 years, 15 million people will turn 65. So by 2030, 79 million, or 1 in 5, will be 65 years and older. And the reason that's so important to those of us in the arthritis field is that 60% of those over 65 years, some say 66, are going to have osteoarthritis. That's huge. That's a huge burden. And for the first time, we're going to have more older adults, and you all know these statistics, but it just helps lay the groundwork here. But there are going to be more older adults than there are 5-year-olds. So that's a major change in our country's demographics. And a lot of these people are going to need long-term care. Here again, cost burden. And just in our county alone, just in 13 more years, 1/3 of our population is going to be 50 and up. So, and a lot of things have added to this. Yes, we baby boomers are aging, but life expectancy rates are going up, and people are having less babies now. So the older population is going to be way more prevalent, and we're in a great field to be change agents. Next slide. So let's get down to the nitty-gritty here. What really is arthritis? Just basic definition, arth refers to any joint. There's like 208, I think, some unions where bones come together and are joints. Itis is inflammation. But not all types of arthritis are really autoimmune types disorders, but there is a level of inflammation in all kinds. We don't have cures. Self-management's critical. Medical management's critical. It's painful. It's a big problem. That's the best way I can sum up that slide. Next slide, please. There's lots of different kinds of joints we have in our body. If you'll look carefully there, as it's sort of dissects out, look at the shoulder joints and how they're balls and socket. It kind of pivots around. Then there's the pivot joints in the neck, the ellipsoidal joints in the wrist. Look how they go side to side, up and down. The hip can pretty much go in a roundabout fashion. The knee is a hinge joint, pretty much just like the elbow. They go up and down. Next slide. So a joint, here again, two bones come together, they make a joint. You can see on this slide, and I think my next slide might talk about this more so. Okay, yeah, let's look at this slide instead of the last one. If you'll look at the knee over on the left, cartilage is between those two bones. That's the way God planned it all. It's a cushion. It covers the ends of the bones where the nerve endings are encapsulated up in the cartilage. And you see how that shows up on the left as a nice, good space. That tells me right there that cartilage is intact. But over on the right, you don't see as much of a space. You see where the bone ends are actually have touched. They've come together. Little bit of space maybe over there on the left, but on the right, those bones are rubbing, and they're rubbing and rubbing and rubbing. And what do we see then? They're little tiny little shavings, microscopic shavings that are coming out into that joint space and causing the irritation and causing the pain to be even worse. Next slide. So this, sometimes I think it's easier to look at it like this. My coworker drew this one time, and we've used it forever because it's just such a simple little diagram. But you look at the yellow, the two bones come together. Over the ends are the cartilage, or some people call it gristle. It's kind of like the tip of your nose. If you'll just sort of feel the tip of your nose, it has a little bit of a give to it. And it doesn't have a blood supply, so unless we move our joints, that's the only way that blood's going to nourish and get around that cartilage and keep it healthier. Move, there's that word again. Look how the relation of the muscles. Muscles join up by tendons on either end of the joints. Ligaments doesn't really show on this page, but a ligament attaches bone to bone. Things can go wrong in the ligaments. The synovial fluid. That's there to lubricate. It's all encased in a capsule. And I think that's about all I need to say on this slide. That's just normal anatomy. Next slide. Continuing on with that, I don't think I pointed out the bursa sac. The bursa sacs are in strategic places pretty much, throughout the different joints that, you hear people say they've got bursitis. Well, that because of usually over irritation, or it can often be from the weekend warrior who does everything that they've never done for a while, cleaning and washing windows and all that, and they irritated it. So it's from over irritation. So it's a double-edged sword on that delicate balance too, keeping our bursas from flaring up. I think you pretty much have everything you need to know on that. Okay, here's a joint. Think back to that x-ray. Here it is in a simple diagram, and look how the bits and pieces of the cartilage are worn. That wearing, those bone ends come together. We used to say this wasn't any type of inflammation going on in this type of arthritis, but that's not really true, because when we have this, we lost our slides again, but as long as you can hear me, when we have that type of irritation going on, we do have local inflammatory response. The body is so good, we've got, something's wrong, so we're gonna stir up something in there and see if we can't fix it. And that's just that's the normal immunity, though. It's not abnormal immunity. It's because our body's good at trying to fix it and get everything calmed back down. So when that happens, though, there's all those little tiny shavings that I like to refer to as that are out in that joint space, not room enough for that. So what do we have? We have swelling. We have redness. We can hardly move it. It hurts to do anything. Yes, this type of arthritis is often associated with aging, but it can start up in somebody a whole lot younger, especially if they've had accidents or anything that would cause a malalignment of the way those bones come together, can cause the wearing process to be hastened. Yes, our weight can play a big factor in this. But as I said earlier, it's not always the case, but if you do have excess weight, yes, it's placing more pressure, that's the word I was trying to get to, on the joint. Next slide. And here's a classic look at osteoarthritis in the hands. I think, and a lot of people will look at someone's hands like this, and that person's saying, oh, I've got the rheumatoid arthritis. This is not rheumatoid arthritis. This is where, if you think about it, those end joints, the distal interphalangeal joints that are at the end, and the one up from that, think about that. Go back to that picture in your head where that cartilage pad is worn off. Well, it wears and wears and wears, and over time, it reshapes that joint. So those persons are left with these sort of nodules, Heberden nodes or Bouchard's nodes, named after the scientists that discovered that, and there's usually pain as this is going on, as this rubbing is taking place, but once it's come full fruition and the cartilage pads are rubbed off, this is the end result. And it tends to be not as painful after they go through the whole wearing process. Next slide. Okay, here's a whole nother ball game. This is my love. This is what I like to talk about. Rheumatoid arthritis is an autoimmune disease. This is not something we play around with. We don't play around with any of the types of arthritis, but this one here, if not treated, can really get out of hand, and this same type of abnormal immunity can start taking place in organ systems. So look there at that lining. Remember how that lining supposed to look over on the left, just nice and pretty and smooth. Serves as a lubricant. It helps keep the joint area fluid. But because our immune system, as it's circulating through our body and normally searching for problems, for germs, I guess that's the best way to say it, comes upon something there in the linings of the joint that it thinks is something it needs to set up an attack on. But in reality, there's nothing there that should have started this immune process. So because this is happening and the body is trying to attack normal cells within that little joint space there, there's substances that spill over. These are toxic to the joint lining. They can cause deformities. This type of arthritis must be treated in order to keep our joints functioning. Otherwise, it'll be back to years and years and years ago. This is the type of person that ended up as an invalid. Because we're talking about linings, think about it. There's a lining around our lung, the lining around our heart. These are areas that also can be attacked by this autoimmune process called rheumatoid arthritis. Next slide. And here's the classic hands that have gone on for a while. And no matter with treatment, some people, particularly in years past, these types of things happen very aggressively. Doesn't happen as much anymore, but you're still going to see folks that were a part of a time and period where we didn't have as good of treatments. Look at what's called ulnar deviation, where there at the knuckles, they're sort of pulling over to the right. This is because picture that lining again, picture all those structures around it and how there's just a displacement because of that. Everything's gotten enlarged there and stretched, so tendons tend to move, and we're left with these kinds of conditions. There's all kinds of names for all these different deformities that you see in these hands. That person has a hard time gripping. That person has a hard time putting their clothes on, doing all the normal things that we all take for granted. Next slide, please. Oh dear, fibromyalgia. Whew. That's a deep subject, and one in which I have come to appreciate over time. It's not my place to determine if somebody has pain or not, just because we can't find a very, very good scientific evidence for the cause of that pain doesn't mean that person doesn't have pain. But this, you know, some of the things that we've certainly learned about this is that we used to think it had a whole lot more to do with those naked ladies you see over there at the right, and all these tender areas on the body where a physician would press on them and people would exclaim just how much they hurt. So we're trying to look for reasons behind that had more to do with, well, something in the muscle. What is it? And it's kind of come full circle to be explained now as a central pain processing problem, because pain, you know, is all registered by the brain. And the signals have to come up through the spinal cord area and up to the brain to be registered as pain. And all of pain management is pretty much centered around preventing as much of the pain message from getting up to the brain. So fibromyalgia is considered a pain processing problem now, where these substances that control our pain just basically get out of sync. We can talk more about that later if you want to. Next slide. This slide, I kept osteoporosis in there because it certainly can be a reason for older adult chronic pain. Not usually until there's a breakage in the bone. You know, our bone's forever remodeling itself. I think I used to think it was just like our skeleton, you know, we see in horror films and stuff, but it's alive and growing, and these cells that make bone, called osteoblasts, we want that activity going, but all the time osteoclastic activity is going on as well. So it's a delicate balance here of making sure we keep more bone than we lose. Next slide. So the physical, it all comes back down to the fact that it's going to affect us physically and emotionally. Pain's a central common denominator there, but limits activity, very unpredictable about activity. This really messes with people in that one day they feel like something, another day they don't. Families don't understand when you can do something one day and you can't do it another day. It does tend to socially isolate people, as we've mentioned already. And these emotional issues too that lead us into all the grief stages, all that comes into play when a person has the type of pain that we're talking about when we're talking about arthritis that goes on and persists and nothing seems to be working to help it. And then obviously there's surgical risks. You know, surgeries are an option, but they don't come without risks. And then there's often medication issues that what might work for a little bit doesn't seem to keep working beyond that. So it's a big problem. Next slide, please. I like this version of the cycle of pain in that, and you've all seen this before, in that, you know, the pain starts up. We know in the arthritis, a lot of them, what the actual cause is. Natural reaction of the body is going to be to clamp down muscle. It's the body's protection. It's going to clamp down muscle around that joint to try to stabilize it. This goes on and on and on, and more pain and more pain. Our body can go into sort of a fight or flight stress reaction. People will start having symptoms way beyond just the pain of arthritis. You know, the headaches, the not getting a good breath, the anxiety, and all, here again, coming on down around the curve here, the fear, anger, and frustration. And then that sends us into the depression stuff that Dr. Newman's going to talk about. And then fatigue. People, particularly with the autoimmune types of disorders, there's a certain amount of fatigue that those of us that don't have that kind of autoimmunity going on in our body, we just can't understand that level of fatigue. But fatigue also happens in persons that have arthritis that are not related to the immune system. Next slide. And this is just another way that I like to look at it too. This little diagram was around before, and it talks about, you know, here again, the disease pain, the tense muscles, it's just our body's reaction, that whole psychological stress thing that comes along leading to those different emotions and feelings there, and then the fatigue. Next slide. So what are we going to do about all this stuff? Well, medications. It certainly depends on the type of arthritis as to the type of medications that's used. The anti-inflammatories are certainly used in both osteoarthritis and rheumatoid arthritis, but they really have to be watched real carefully, since some, are available over the counter, the ibuprofens, the naproxens, or another word for that is Aleve, and physicians prescribe ones, and then they, there's ones over the counter as well, and we have to watch that our older adults don't over medicate and use things over the counter, because it must be safe since it's over the counter. But we have to, obviously, most of us would know to worry about stomach ulcerations. And even the medication Tylenol. Tylenol, here again, over the counter, it must be okay. Well, it's not. Particularly in an older adult, it can be abused and lead to liver toxicity. In the case of rheumatoid arthritis, as I mentioned, the autoimmunity is so complex and different substances are spilled over at different points in that cycle. Thank goodness now we have new classes of medications that can hone in at certain points in that cycle, rather than having to rely all the time on corticosteroids that tended to suppress all of the immunity in our body, which that sets up lots of issues there. Now, they still do use corticosteroids, definitely. A lot of people have to have that to get through a painful flare, but the medications of the biologic have certainly revolutionized the treatment of the rheumatoid arthritis autoimmunity. There's surgeries, and namely the total hips and the total knee surgeries. They serve that purpose, y'all, to resurface the ends of the bone. When you resurface the ends of the bone there, you remember those nerve endings were what were being exposed, that's carrying those pain messages. It tends to really help a lot. Now, can things go wrong? Yes. It's not something to go into lightly whatsoever. And a lot of times with an older adult, the commitment they have to make to the therapy is sometimes overwhelming to an older adult. Relaxation techniques. Now, this is why those of us that are really gung-ho about these self-management programs, how much this information is stressed in those. And I don't know if you all are like me, but I sometimes have a hard time convincing people that this is the way to go. And Dr. Newman will talk a little bit about this too, using guided imagery or the progressive muscle relaxation techniques. They really help. They really help a lot to help refocus you onto something beyond the pain. But honestly, it has to become a habit, and we have got to be able to convey to the person, it will work. It will take some time, but it will work. And then the last thing there that I'm basically screaming is that movement is the answer, or part of a big, huge chunk of the answer in dealing with all the arthritis, is because what happens when we move a joint? It gets the blood supply in there. Everything gets, it's just a healthier joint when it's moved. Next slide, please. I'd like to put a little plug in here for two resources, the Arthritis Foundation and the Osteoarthritis Action Alliance. I can't tell you how much information I get from the Osteoarthritis Action Alliance in Chapel Hill. And Dr. Lee Callahan was a big part of authoring the Walk with Ease program. And I think many of you are contemplating using that and working some along with the Parks and Rec. I know that's what's happening here. And I'm excited to get to be a part of that, because as the arthritis services, we're going to be doing class zeros for their participants that they're trying to organize with Parks and Rec, because we all feel that's important, that people understand, you're making a commitment to this, to come together and learn the benefits of a walk program. I mean, it's so easy, I think, to say, oh, I won't go do that today. I'll just do it at home, and then you don't. This is geared toward group work, warm-ups and stretching, and it's just a much more organized way to learn that walking does help. tempered. It's a delicate balance there. You know, it's easy for me to say this. I don't have problems with my knee. And there might be someone out there listening to this webinar going, well, that's easy for you to say. And that's why I say everything is a delicate balance, but doing something is better than not doing. Next slide. This slide comes from the Osteoarthritis Action Alliance, and I love it because I think this sums up everything. People have pain. What do? We don't move. Look, as we're coming around the right there. Then the lack of physical activity gets into more problems with being heavier. And then being heavy, look at those 3 little red dots beside that and what that in turn can rev up and cause, there again, more problems. So, and then the obesity comes up, increasing more pressure on the joint and more pain. But that common denominator, that yellow right there in the middle, is saying a lot there because it can, I feel like that the Osteoarthritis Action Alliance put that there because that's just how important the whole concept of moving. I mean, back in nursing school, I mean, we knew when we had older patients that were bedridden that we needed to move their joints, and certainly there were patients even way before then that had not been moving properly, and their joints were indeed frozen. And so, I mean, we've always underscored and knew that the thing with movement, but I think it's become more and more of getting out into the public that this is the way to deal with arthritis of many types. Next slide. So here again, let's move. We've got, I think it's so great now that when you go to the doctor, when they're doing your vital signs, they get, you know, all the way up to the temperature, pulse, respirations, blood pressure, and they're asking us about our pain levels now. And very often I'm finding that the activity level has been added to that assessment when we go to the doctor. If they don't ask you, you tell them what you're doing. Next slide. And here again, that quote, more time spent by all of us outside the healthcare system than in it. So what we're doing during this time largely determines our symptoms and our quality of life and how much we're going to need to use the healthcare system. Self-management is where it's at, y'all. You're in the right field. And this is the new reality in chronic disease care. And I'm going to turn this over to Dr. Newman now.
Okay, next slide, please. We know that emotions and that our physical activity are entwined. These are so important for us to realize that they are controlled by some of the same body chemicals that cause pain. So we know depression is serious. It can lead to alcohol and drug abuse. It causes family problems. Depression often occurs with health problems. We know that depression can hinder your self-help attempts. Next slide, please. It's important, and I tell people this, both as a therapist and a nurse, that we go around saying, oh, I'm depressed today, when what we really mean is that we are blue today. And I think most of us understand that. But when you're dealing with depression with a patient who has that, we need to take that very seriously. It is not the blues. Blah days are Monday. Blah days are the blues. Depression is when you have these symptoms and need to see your healthcare provider. Misery lasts for 2 weeks or more. You have little interest in what you used to enjoy doing. You're feeling lousy about yourself and everything else. It is a pervasive guilt, I should be doing better, I should be able to pull myself up by the bootstraps, all of those things that we hear people say. And there are still people who don't believe that depression is real. But let's talk about what it really is. Next slide, please. So we said it's sleeping too much or too little, eating too much or too little, frequent tears, inability to concentrate, feeling anxious, or wanting to hurt yourself. Now, we've all had some of these feelings at one time or the other, but we're saying, or I'm saying to you as a professional, if it lasts more than 2 weeks, you need to see a healthcare provider. Next slide, please. Oh, I don't have those symptoms. About 75% of the time, people with chronic pain and depression have some of these symptoms: irritability, anxiety, rather than the prolonged sadness that we think of when we talk about depression. Men mask depression through alcohol or drug abuse, anger, or working excessively long hours. So this is the piece that I want you to hear. It's not what you have normally thought depression was, but these that I'm telling you about, this irritability and anxiety or increased alcohol or drug abuse, these are all symptoms of depression. Next slide. And for women, it can be responsibilities at work, caring for children, aging parents. These all may contribute to depression. Next slide. So like arthritis, excuse me, some types of depression are genetic. And you remember the old serotonin and dopamine brain involvement, that they have different patterns. We now know that chronic pain raises this level of substance P and the serotonin level drops. So as that inversely occurs, this may explain even in the absence of depression. Next slide. So my hair, my arm hurts today. I can't comb my hair even. And what about tomorrow? What's tomorrow going to be like for me? Now, if you're like me, you have bad hair days, or you have days when everything goes wrong. And you say to yourself, is this the way life is going to be? Well, you add pain, chronic pain to that, and these stressors can even cause the most upbeat person to become depressed. So chronic illnesses such as arthritis and some of the other ones that Cindy named can contribute to clinical depression. Next slide. But depression may also contribute to pain and disability. So we often ask the age-old question, which came first, the chicken or the egg? And in the case of our treatment, it doesn't matter. We know that pain usually precedes depression, but depression can also lead to pain. So we say it's no laughing matter, but it can be overcome. And here are some of the ways. Next slide.
And I just want to mention 5 minutes.
Okay. So depression is treatable. It may take time to find the best combination for you. The important thing that I think you need to understand is that depression is not a weakness. You cannot will it away. It's not a matter of character. And the most important thing that you can do is, if you are in this condition, or if you have arthritis, or you have another condition, is to see your specialist. And in the case of arthritis, this is your rheumatologist. Encourage your people to start by seeing their rheumatologist. Next slide. So we know certain meds can cause mood changes. Rule these things out, and often working with a psychologist, a social worker, a psychiatrist, or an advanced practice nurse who's a nurse practitioner will help. What we're looking for is behavior change. And we know that in spite of your arthritis, you can engage these people in problem solving, because I truly believe that people are capable of solving their own problems if they know how, and if we teach them how to do it. Next slide. So here are some of the ones. We know that regular exercise, relaxation techniques, Tai Chi is a wonderful way for people with chronic pain. Have your family or friends help you set realistic goals. And that is so important, because we tend to be the type of people who want to do it ourselves, but we have to depend on other people. So we know that chronic disease or self-management pain is what we need to work on. Next slide, please. So we've said some of these things before. Spend time with friends, do things you enjoy, even when you feel down. You've heard the old saying, fake it until you make it. And I don't know about you, but if I put on if I put on a little makeup, I feel a little better about myself. I feel more like getting out and trying. Next slide.
That was
Okay, so just to reiterate, go to the next slide.
I think we're back to the beginning. I think that might have been your last slide.
that was the last slide. Mhm.
Okay, so
So what we're saying is if we keep on doing what we've always done, we'll get what we've always gotten. So teaching people to learn to take control of their illness, to learn these self-management skills is as much of an emotional task as it is to get them to do the physical exercise. Thank you.
Thank you so much to Dr. Ann Newman and Cindy Barrier for all this great information that helps us understand the different forms of arthritis and fibromyalgia and depression a little bit more. And we're going to go ahead and switch gears now, and we're going to continue to explore a little bit more about how medications and the use of opioids can affect chronic pain in older adults. So we're now switching to Heather Carter.
Hi, good afternoon. Thank you for having me. This is a pretty extensive topic. I'm just going to kind of hit the high points. It's very in depth, as you probably know, just from the media coverage it's getting today. Next slide. So, of course, we know people are aging. That's why we're here. But North Carolina especially ranks 9th nationally, both in total population and in the number of people 65 and over. So by 2025, 1 in 5 North Carolinians will be 65 and older. So just looking at these numbers really gives us an idea that, of course, the country is aging, as is our current population. Next slide. So this is just a breakdown of the differences. And if you look at 65 plus and 85 plus at the bottom of this wonderful table, you'll see that the change is, the percentage of change is 67 and 107 respectively. So those are our biggest groups. Next slide, please. So talking about pain in older adults, 1 in 5 older adults experience pain or report experiencing pain. I tend to think that's a little low, self-reporting. And there's also, of course, those persons who have cognitive impairments who may not be able to describe their pain or recognize that they are in pain. So 18% of adults age 65 and over are taking pain medications regularly. Some of them are prescribed, some of them are over the counter. And 1/5 of adults 65 years and older said they had experienced pain in the past month that persisted for more than 24 hours. And I think a lot of people just tend to think, oh, you're getting old, you should be in pain, you've got arthritis. And a lot of times older adults may be ignored when they say they're in pain. And almost 3/5 of adults 65 and older with pain said it had lasted for 1 year or more. That's a long time without getting any kind of relief. Next slide, please. So again, older adults often experience chronic pain. And the pain experienced by older adults is more complicated than pain experienced by younger persons, basically because most older adults have several comorbidities and are on several medications already to treat those chronic conditions like hypertension, diabetes, COPD, etc. And sometimes their pain is a result of all of those health conditions that they have. And again, like I said earlier, I really do believe that pain in older adults is underreported and definitely undertreated. Again, I think there's this societal value or belief that if you get older, of course you're going to hurt and you're going to be in pain, and that's normal. And I don't think that's the case, definitely. Next slide, please. So what are opioids? Opioids are a class of drug that are derived from the opium plant. So back many, many years ago, there were the opium dens. I did a little research on that. And the last opium den was closed in, I think it was 1954, but it was only after legislation was put into place and raids were made on these quote-unquote opium rooms that were illegal. So just to talk about opioids today, they're the pain relievers that we hear people talking about all the time: oxycodone, hydrocodone, codeine, morphine, fentanyl, and others. And then fentanyl can be made, is legally prescribed, but it can also be illicitly prescribed and used and added to heroin. And that's really what is causing a lot of these overdoses and deaths, is the fentanyl that's added to the heroin, because fentanyl is so much stronger than heroin. People who are heroin users, might think they're getting just plain heroin, when in fact they're getting just maybe a little bit of heroin and a lot of fentanyl, and they use the drug and they overdose because of the strength of fentanyl. Next slide, please. So again, this is just talking about natural and synthetic opioids. There's different classes. Next slide, please. So why are opioids so addictive? Well, they make people feel better because they interact with the opioid receptors on nerve cells in the brain and nervous system to produce pleasurable effects and relieve pain. So 20% of people who are prescribed opioids will become addicted to them. That's just genetics and brain chemistry. If you have 100 persons, or doctor has 100 patients and he or she prescribes opioids to all 100, 20 of those are going to become addicted to them. Next slide, please. So drug overdose is now the leading cause of accidental death in the US. And you can see the figure there for 2015. That's the latest that I could locate. But that's a pretty significant number. Next slide. So this is a breakdown of opioid-related deaths among adults 60 and over for fiscal year 2017 for North Carolina. So the total is 65, which probably doesn't seem like a great amount. But if you look at the data that goes along with the 65, there's a lot of ambiguity in terms of, was this accidental? Was this intentional? And I think a lot of times there are accidental overdoses, but in older adults, they have so many other diagnoses that those diagnoses can be attributed to the cause of death versus opioid overdose. Next slide, please. So this is just another breakdown of the age groups and then the number of deaths by race. So females are more females than males died as a result of their opioid related overdoses. And that's pretty It's pretty consistent with the older research about suicide. Women are more likely to abuse medication and alcohol when they're attempting suicide, and men are more often likely to use firearms. However, women are becoming more and more interested in guns, but are using them more and more in their suicide attempts. Next slide, please. So DHHS has a plan. This is one of the Secretary's top 3 initiatives for DHHS. So the current plan is for 5 years, and the major goal is to reduce the opioid overdose deaths by 20%. And if you'd like to check out the plan, it's on DHH's website, and there's a link to it at the bottom of that slide. Next slide, please. So what are the strategies? Well, to coordinate the state's infrastructure to tackle the opioid crisis, and this is probably going to result in some sort of database management so that doctors, before prescribing opioids, can see if their patients are quote-unquote doctor shopping, and see if they're getting opioids from another physician, or you know, if they just recently got the prescription, that kind of thing. And again, that goes to reducing the oversupply of prescription opioids. The new legislation, which I'll get to in just a little bit, really limits how much a doctor can prescribe to persons based on their different diagnoses. So the other thing we talk about is diversion, meaning diversion of drugs. In the previous presentation, the presenter spoke about grandchildren taking their grandparents' medications. That can happen. You know, you see diversion of prescription medications in long-term care facilities, hospitals, etc. And then the flow of illicit drugs is another point of the plan. So another thing that the DHHS plan wants to do is increase community awareness and prevention. I'm not sure if anyone has seen some of the posters that, well, we've put them up here at the division, but it's basically a PSA, and it shows a young woman, and it says something to the effect of, she got her eyes from her father, her hair from her mother, and her drugs from her grandmother's purse. So keeping them locked up and secured is a big part of the plan. The other thing is to make naloxone widely available, and that has been done. I know that the secretary, when I was at a presentation recently that she gave, indicated that many units had been ordered, and in talking with EMTs and nurses who work in the EDs, they're using it quite a bit. So the other thing the plan wants to do is expand treatment and recovery, and measuring the effectiveness of these strategies based on the results is the last part of the plan. Next slide, please. So the metrics, basically this is how North Carolina is going to measure its effectiveness of the plan. Reduce the oversupply of prescription opioids, reduce the diversion and flow of illicit drugs, increase the access to naloxone treatment and recovery. Next slide, please. So I don't know if you've heard of the STOP Act, but it's the Strengthened Opioid Misuse Prevention Act. It was House Bill 243, Senate Bill 175. It passed unanimously by both parties, and it was signed into law by Governor Cooper in 2017. So again, the intent is to reduce the supply of unused, misused, and diverted opioids circulating in North Carolina. And that is talking about, you know, if you have medications left over, to dispose of those properly. Some of the drugstores are offering a free place to, quote unquote, turn back your drugs, and they will dispose of them properly. So that's a big push as well. Reduce doctor shopping, like I mentioned before, which can be done with that database. Improve care by requiring prescribers to use tools and resources that prevent inappropriate prescribing. Again, going back to that database, and also just different modalities to address pain. You know, some of the non-traditional methods, like massage, acupuncture, meditation, etc. Next slide, please. So the basic provisions, there's a lot of provisions in the STOP Act, but the two basic provisions limit a doctor's ability to prescribe no more than 5-day supply of opioids during an initial visit to treat a patient's pain like a broken bone. Doctors can prescribe a bigger supply during follow-up visits. But this is a way to just kind of get a handle on how many pills or how many opioids people are being prescribed, because the usual prescription is for 30 days. And often medication isn't needed for 30 days to address these acute pain issues. Now, this STOP Act does not apply to cancer patients and others who are being treated for chronic pain. Next slide, please. So what are some next steps that you can do to help with the epidemic? Start talking about it in your communities. A lot of people don't like to talk about their family members potentially misusing medication. That's something that we see a lot of times with older adults, you know, and anybody. The doctor says I should just take one, but, you know, I think 2 would be good. 2 would make me feel a lot better. So talking about those kinds of issues, and also recognizing that there is that diversion and people are stealing prescription medications from family and friends and using it for themselves. Most often that is how drugs are being diverted. And again, you know, real people may not even recognize that they are not taking the prescriptions correctly. Maybe they don't understand how the prescription is to be taken. So getting some good education from their physicians and pharmacists are important. Again, we talked about the locking up of medications as a deterrent. You know, it's not going to keep people from diverting medications, but it's going to be just one more step that's going to make it a little harder to divert those medications versus leaving the opioids in the medicine chest or the medicine cabinet. Talk about naloxone, how it works, encourage the use in your respective communities. Another way is to support evidence-based programs funded by Title III-D of the Older Americans Act, and senior centers to provide information about opioids in the current epidemic. Next slide, please. So here are some of the programs that meet the 3D requirements and address chronic pain, the chronic pain management, Tai Chi, exercise classes, and home meds. Next slide, please. So what are some things, and I know there's some senior center folks on the line, and so that's why I wanted to talk about specific things at senior centers, and I know that there's also some 3D people on the line, so that's why I wanted to talk about the evidence-based. So ways that senior centers can help is offer evidence-based trainings listed on the previous slide, have speakers present on chronic pain, opioids, and the importance of securing medications, because that's not necessarily something that people think about, that their friends or family may be taking their medications for themselves. Have a medication review day. Some senior centers, I believe, call it the red bag day. Some senior centers call it the brown bag day, but basically it's where you can provide education to the participants about their medication and make sure they're using them correctly. And again, make education available to participants about locations to safely dispose of unneeded or expired medication. That's a big one because, you know, for a long time, we were told to flush the unneeded or expired medication. Now we're learning that that's not a good idea because it contaminates the water supply. And, you know, to be able to dispose of it in a way that is safe and effective can be, you know, can take time. So having these drop-off points is really nice too. Next slide. So those are the references that I used, but basically that's just the kind of the tip of the iceberg about older adults and the opioid epidemic. So thanks so much for your time.
Thank you so much, Heather, for this data that just helps to put a better picture on this horrifying, you know, reality here in North Carolina for older adults. And especially the next steps can really help us as we're figuring out what to do in our respective agencies. As we have been listening to the guest speakers, I have received a couple requests for the PowerPoint slides. I think that the participants today were all very much resonating with the information and the data. And so I'll be following up with the guest speakers to see about posting their PowerPoint slides on our website, healthyagingnc.com. On the page right now, I do have where we keep our pre-recorded and recorded webinars. So if this intrigues you and you want to learn more about the Healthy Aging Network and about the evidence-based programs provided through the NC Division of Aging and Adult Services, I welcome you to check out that slide. And I also want to let you know that healthyagingnc.com is a place that posts the area agencies on aging and their work with the senior centers across the state. You can post at no cost to our website so that people from around the state can see where programs are taking place. We have a resource tab, a program tab, and a trainer resources tab. And I do want to highlight the trainer resources tab has all of the required paperwork forms that are needed for the evidence-based programs, as well as sample brochures and flyers and different types of media that you can use. So I welcome you to check that out and to let me know if you have any questions. And I do want to give a heads up for the aging specialists that are on the line. We are holding an in-person aging specialist meeting in Salisbury on Friday, March 2nd. And we want to make this a working meeting and really cater to your needs with evidence-based programs in chronic disease and falls prevention. And the webinar today, a big thank you to Centralina Angel Soy helping me to plan it. And thank you to the guest speakers that we had today, Cindy Barrier from Arthritis Services, Dr. Ann Newman from UNC Charlotte, and Heather Carter from the NC Division of Aging and Adult Services. I will be posting a link to this webinar to the healthyagingnc.com website, and I will be following up with the guest speakers to post their PowerPoints. So I am going to go ahead and thank everyone for being on the line. And thank you to our ACL grant funding that makes this webinar happen. And please feel free to reach out to me if you think of any other questions. I am putting that slide up on right now. I'm Jeannie Dairagi, Project Manager at the Healthy Aging and NC Initiative. So again, thank you to all the guest speakers, and I hope that you have a great rest of the day.
Thank you for the opportunity.
Thank you.
Thank you.
Thanks.
Thank you.